A very good afternoon to you all. Medic is very excited and extremely honored to host this three-part webinar on the use of QST in clinical pain practice. The distinguished team of pain specialists from Leiden University Medical Center in the Netherlands are the experts who will be sharing their scientific and clinical expertise on this subject. Today, the first session of 3 sessions will be hosted by Professor Dahan. A few short notes for today. You may notice that you're muted. We welcome your questions very much. Please ask them in the Q&A panel of your navigation bar. We will try to tend to all of them, but time constraints may limit us. So if we haven't tended to your question, please write us so we can try and answer them after the webinar. And finally, you will receive a recording of this webinar after we have processed it to the mail with which you have registered. Professor Dahan, take it away.
Good afternoon, ladies and gentlemen. Good morning or good evening, wherever you are. It's a big pleasure of mine to present today's webinar. This webinar is part of a series of webinars, the first of which is today, in which I will be discussing some general concepts around QST. Next week, we have a webinar presented by my colleague, Monique van Velzen, who will be talking about the practicalities of QST. And finally, in 2 weeks' time, there is a webinar on QST and treatment effects by my colleague, Marieke Niesters, who's head of our pain clinic. Well, let's start with my presentation. Let me share my screen for you. Here it is, and let me start the presentation. As you can see, it's quantitative sensory testing from science to clinic and back. It's a general presentation, all related to QST, all the practicalities of QST and other items that I will be discussing today. As you can see, in our lab, and we have an anesthesia and pain research unit, we use several of the Medox devices, the TSA2, the QSense, and the Algomet. And as you can see, the TSA2 and the QSense are able to apply cold and warm stimuli. And you can see the thermode, the Pelletier element there. And what is so special about the TSA2, it's a new device. It's a follow-up of the pathway, and it can also hold 2 thermodes, so you can also perform conditioned pain modulation with it. I will be discussing those items today. First of all, my conflicts. I'm an associate editor of the journal Anesthesiology. I'm related to journals Pain, European Journal of Pain, and I'm a special sections editor of Frontiers in Pain Research, and I do the special section neuropathic pain. We perform our research in our anesthesia and pain research unit, and you can see that we have supports from various companies, but what I'm most proud of is that we have a strategic collaboration with the FDA, and we recently obtained a very large award from the FDA to study opioids and opioid-induced respiratory depression, all in light of the opioid epidemic in the world. So let's now start with 2 patients. And here you see on the left a female patient that has pain, lower back pain, since 3 months. She's a housewife with 3 children. On the right side, you see a more or less similar patient. It's a male. He also has lower back pain since 4 months, and he works as a taxi driver. And the intensity of the pain is more or less the same in NRS. Depends a little bit of the time of the day. It is around 4 to, in some instances, even 6 or 8 on a scale of 0 to 10. Patients were seen by us. They were diagnosed as aspecific low back pain, and they were both treated in a similar way. The patient on the left had no effect of therapy. The patient on the right had satisfactory pain relief, and he can work again. 2 patients with more or less the same underlying disease, but they respond very differently to treatment. Now let's go to the next 2 patients. These, again, a female on the left, a male on the right. They both have type 2 diabetes. The one on the left is a little bit heavier than the one on the right. but the severity is also a little bit different. The patient on the left had a more severe presentation of neuropathy in her arms, in her hands, and in both of her feet. And this was length-dependent polyneuropathy. It was severe neuropathic pain, and she was treated with anti-neuropathic pain medication, and she had satisfactory pain relief. In contrast, the guy on the right, he had initially milder presentation of his complaints, of his symptoms, with only symptoms in his feet, but he did not respond to pain therapy. So how is that possible? We have 4 patients here, 2 of which have lower back pain, 2 of which have diabetic-related neuropathy, and only 50% of patients have benefit of treatment. This is what you find in your general practice. It is a complex observation, and we have little knowledge initially how to treat of our patients. So we still are in a phase in which treatment of patients is based on trial and error. So the questions what I have, again, patients with similar underlying disease and symptoms respond differently to therapy. Can we improve our therapy success rate? Should we focus on phenotype rather than underlying disease? And what is the link between phenotype and treatment efficacy? And should we determine phenotype based on QST? Well, first of all, I would like to show you there's a big difference between genotype, of course, and phenotype. I don't have to tell you that, but just to be sure, genotype is based on the difference on your genetic makeup, your DNA, your genes, while phenotype is based on how you look. And I give the example here, genotype on the left, differences in genes between all of us, but on the right side, you can see that this leads to differences in how we appear. In this slide, you can see 5 mice, and they're all different. They differ only in one aspect, and that is their skin color. So we have a black mouse, a white mouse, and a gouty mouse, and that's the phenotype. So that's what we will be talking about. We will not be talking about genotype today. Why is that? Well, it's difficult to determine the genotype of patients, and we know little about which genes determine our pain sensitivity, the development of disease, but maybe, it's a big maybe we can determine from the phenotype how patients appear, their symptomatology, are there similarities, and maybe these similarities may lead the way towards improved treatment. Now, what is quantitative sensory testing? And I went to Wikipedia and I looked it up, and this is what Wikipedia says, that QST is a panel of diagnostic tests to assess somatosensory function. And it's used for research, but it's also used in the diagnosis of somatosensory disorders like pain. And it uses a panel of tests to determine various sensations like hot, cold, touch, vibration, etc., etc. And like I said before, in our lab and in our pain clinic, we have the possibility to use the TSA2, the QSense, and the Algomet. The QSense and TSA2 give you more or less similar output. I will show you that later. And the Algomet gives you pain pressure. Now, let's continue on this QST. So we talk about the panel of diagnostic tests. So what are we talking about? It's a whole series of tests. And these tests are developed to determine the functionality of specific fibers, nerve fibers in the skin. And on the top, you can see on the right side that most important fibers related to sensations of pain and heat, cold, touch, are the A beta fibers, the A delta fibers, and the C fibers. And they differ in their speed. The A beta, for instance, myelinated, is a very rapid nerve. So the action potential travels quite rapidly to the central nervous system, while the C fiber is unmyelinated and it's a relatively slow. And you can see here, A delta carries touch, A delta carries cold, pressure pain, and C fibers carry mechanical, chemical, warm, cold pain signals. And the different tests from the QST give you a different indication of the functionality of these fibers. And I will not go through this slide. I hope you will download the presentation at one point. You can have a look at it, but you can also find it on Wikipedia. You have different tests. I will give you an example of some. Let's go to, for instance, a mechanical detection threshold. Here, determined by von Frey filaments, gives you an indication of the A-beta fibers. Then we have vibration detection thresholds given by the tuning fork, again, A-beta fibers. Then we have, for instance, we go down a bit, the warm detection threshold with the Pelletier device. The Pelletier device is the thermode you saw with the QST devices from EDOC. You can determine the warm detection, and it gives you an indication of C fibers. So we have cold pressure test, also cold pain threshold, also with the Pelletier device, A delta fibers, etc., etc. So these give you an indication of the functionality of the fibers. It gives you much more. For instance, you can see here the pinprick, the wind-up ratio, which is performed by a pinprick test on the skin, and it gives you an indication of amplification, of sensitization, which might be, by the way, segmental on a specific area of the skin, or it might be more generalized, central sensitization. So these tests give you a lot of information. But you need to realize that this is just part of a much larger array of tests that are possible to determine the functionality of sensations, mostly by the skin, but also from other areas. For instance, on top, we have what we call the convocal cornea convocal microscopy. And this determines the C fibers in the cornea. So we have an area where we can actually see the C fibers by taking a photo. And I will discuss it a little bit later on. But we also have much more invasive tests. But here you can see also the QST. QST is an important tool, part of the whole array of tests that are possible. And we aim at easy tests, QST and CCM, to get an indication of the disease, the underlying disease of our patient, but most importantly, the phenotype of the patient. So let's continue. Like I said, the cornea convocal microscopy determines the presence and the quality of the C fibers in the cornea, and it's very easily obtained. And I show you here the cornea on the left side of a normal person and a skin biopsy of a normal person, and you can see the C fibers. They're very easily observed, and you can see that it corresponds well with the fibers in the skin. On the right side, you can see an abnormal cornea, in the sense that it's a patient with small fiber neuropathy from sarcoidosis, which is a pulmonary disease, but also a metabolic disease that causes the destruction of C fibers in the skin, accompanied by pain. And you can see that this patient had abnormal C fibers in terms of density, length, and branching. But similarly, this patient had abnormalities in his skin biopsy in the bottom. So abnormal skin corresponds to abnormal cornea C fibers. This is a very easy test. It's not easily done. You need a rather expensive microscope, and you need somebody that is specialized in performing these tests. And in our team, that's Monique van Velzen. She will be talking to you next week, hopefully also on this topic. Now, apart from the QST, you need to realize that there are other tests possible, and you can make them as complex as you will. And here, for instance, this slide focuses on conditioned pain modulation. And what is conditioned pain modulation? Well, that's the modulation of a painful stimulus when a second stimulus is applied on a distinct area of the skin. And so you have a test stimulus, which is the painful stimulus that needs to be graded by the subject. And you have a conditioning stimulus, that's the stimulus that's applied on a different area of the skin. And it will influence the perception, the sensation of the first stimulus. And you can do it in a very complex way, like we did before. We used the pathway, we used cold water test as a conditioning stimulus, and a heat pain test as the test stimulus. The test stimulus came from the pathway. The conditioning stimulus came from what we called the icy dip. Icy dip is used by athletes to cool down after they exercise. And you can see that this subject puts her leg in cold water, 6 degrees, and she grades her pain. On the left side, you can see what that does. The open circles are the test stimulus without the conditioning stimulus. You can see that when you increase the thermode to a temperature of around 46, 47 degrees, that the patient perceives pain. There's some adaptation. But when you apply a second stimulus, and these are the closed circles here, that you can see that there's some analgesia. The analgesia is related to central top-down processing of pain, in which there is some pain relief at the level of the spinal cord and at the level of the skin. So the patient actually perceives less pain in this paradigm. And this is an important paradigm because we all have this concept of conditioned pain modulation, which is a form of endogenous pain modulation, and it allows us to regulate our incoming pain stimuli. So if you have pain, endogenous pain modulation is activated and you perceive a little bit less pain. And this is an experimental setup to test that. You can see the complex setup, but with the 2 term modes of the TSA2, you can apply it much, much easier. Well, what about treatment effects? Well, I give you here an experiment that was performed by Marieke Niesters and published in the journal Pain in 2011, in which we looked at conditioned pain modulation prior to ketamine treatment and after ketamine treatment. And you can see that after ketamine treatment, the system flip-flops. So the conditioned pain stimulus now does not produce pain relief, but it increases pain sensitivity. And this is related, we believe, to the ketamine treatment. Many patients after ketamine treatment experience some form of increased pain sensitivity. Some excitation of the system occurs, possibly as a rebound phenomenon from accumulated glutamate in the synapse. Very interesting concept, and you can see how you can use it. And I will show you at the end of my presentation some other examples. Now, here you can see, again, the effect of treatment. I will only briefly touch this in relation to, in this case, CPM. We have here neuropathic pain patients that were QST'd. You can see that these patient population in green, it's a control group, and in blue, it's the neuropathic pain population. You can see that in this population, VDT, so vibration detection threshold, there's a hypofunction. The patient doesn't feel it anymore. That's an indication of the large fibers, the A delta, the A beta fiber, but there's also some paradoxal heat stimulation and some hypofunction in the cold and the warm detection threshold, which is C fiber related. So you can see that this is severe impacted patient population. And we looked at these patients and we looked at their treatment, and you can see that what was quite interesting in this population of patients, they had no conditioned pain modulation, so they had an inherent inability to engage their endogenous pain modulation, but with treatment, they were able to re-engage that system, and most efficacious was in this respect ketamine. So we have defined the population on the left, and we see what the effect is on treatment, and especially on pain score and CPM. So the patients with the greatest increase of their CPM also had the greatest pain relief. Very interesting application of the QST. Now, apart from conditioned pain modulation with the QST, you can also perform what we call offset analgesia. Offset analgesia is a temporal and not a spatial form of endogenous pain modulation. As you can see on the left, the black line gives you the temperature applied to the skin. There's an increase in temperature to around 47 degrees, which is kept constant for 5 seconds. Then for 5 seconds, you increase the temperature by 1 degree. After 5 seconds, you go back to the initial temperature level of 46, 47 degrees, and then you go back to baseline after 20 seconds. And look at the pain score of the patients, the Zscores. You can see that upon the increase to 47 degrees, there's an increase in Zscores to around a pain score of 40 millimeters. The increase in the pain stimulation by 1 degree increases the pain sensation, but the decrease of 1 degree causes a rapid analgesic effect to a pain score of 0, despite the fact that the level of stimulation was identical to the first 5 seconds of this pain paradigm, in which the patient scored a pain score of 40. This is quite interesting. This also is a form of endogenous pain modulation, which is possibly central, but there are ample data that indicate that this probably is related to either an effect at the spinal cord or even at the level of the fibers in the skin. And what is so interesting that if you look at neuropathic pain patients, this is a general observation, this is not segmental, but on any part of their skin, even away from the part where they feel neuropathic pain, you can see that they're unable to engage this endogenous pain modulation, this offset analgesia, as they, after the temperature has decreased by 1 degree Celsius, are unable to engage analgesia. The pain slowly goes back to the initial pain value. Very interesting observation, very simply performed with the TSA2, and it gives you a lot of information. In fact, you need to realize that this difference in 100% pain relief on the left in a normal individual versus a neuropathic pain patient on the right allows you to diagnose the occurrence of neuropathic pain. I will show you that later. Here I'll show you that this phenomenon of endogenous pain modulation is age independent. We performed a study, again in 2011, published it in Anesthesiology, in which we looked at age effects. And you can see that even at the young age of 6 years old, individuals, normal children are able to engage this concept. And believe me, they had no idea what they were involved in these studies. And they have very strong analgesic effects. It goes all the way up to an age of 80. You see in the middle bottom panel that the standard deviation are a little bit higher. This is related to the fact that we had only very few individuals in the elderly population. We also looked at male-female differences. There are very small differences, but in clinical practice, I would say that there are no differences between men and women. Now, about the diagnosis, you see a receiver operative characteristic curve, an ROC, and you can see that we determined the ROC for offset analgesia in the diagnosis of neuropathic pain, and we observed that the cutoff value of 88% yields a sensitivity of 90% and specificity of 91% in the diagnosis of neuropathic pain, meaning that in the decrease of your Zscore by 88% towards, again, after the reduction in the 1 degree Celsius increased pain temperature paradigm, that the decrease determines whether or not you have a diagnosis with such sensitivity and specificity. Quite interesting. Now, let's go back to phenotyping our patients. As you can see here, this is a publication from Ralph Baron, very interesting set of studies, and he looked at neuropathic pain patients, and he looked at various subgroups of these patients based predominantly on the QST, but not only on the QST. He also queried these patients. So some patients had burning pain, others had prickling pain, some had allodynia, some had attacks. But if you look at the last three measurements, they are thermal related, numbness related, or pressure related. They were performed with the QST. You can see that the five groups are very different. And these are two populations. So there's diabetic neuropathy and there's post-herpetic neuropathy. And irrespective of the underlying disease, the patterns are more or less the same. And that's where I want to go to, that irrespective of disease, patterns of, well, in fact, phenotypes are more or less the same. And it's all based on these three measurements based on the QST. Of course, you can expand your setup. You could also, for instance, add the convocal microscopy to get an indication of the C fibers in the cornea. But this is what they did, and they were able to distinctively determine five groups independent of underlying disease. And they had another very, very interesting publication that I would like to share with you. And this is a publication from Westerman, again from the group from Ralph Baron. And they had a patient with bilateral spinal cord injury at the level of thoracic 9. And what they did, I show you that on the left side, they did bilateral skin biopsies, they did QST, and you can see the level of pain that this patient had. And what did they show? I show you that at number 2 in the middle figure, you can see that on the left, they had the left leg, both legs, they had full differentiation with complete sensory loss of mechanical thermal sensation. That's because of the spinal cord damage. But a little bit above that level, at the level of thoracic 9, also on the left side, they showed nerve generation with full differentiation, so no sensations whatsoever. In contrast, on the right side, on the level of thoracic 9, they showed cold allodynia as a marker of central sensitization with normal mechanical and thermal thresholds. Very interesting. I show that on the right side in the graph. You can see in black the left side of this patient, which is quite loss of function, while on the right side, you can see that the cold pressure test had a hyperfunction. So there was an increase in function. Otherwise, the white dots are normal. But what's most important, and here's where the treatment comes into it, that the pregabalin was only effective on the right side, not on the left side. So for the first time now, we link QST to treatment. So what we've done so far, we have underlying disease, different diseases with similar phenotypes. And here, for the first time, we have phenotype related to treatment. Now, in our lab, we have various populations of patients. I will discuss today 3 of those: patients with type 2 diabetes, patients with sarcoidosis, and patients with fibromyalgia. And we perform phenotyping based on the QST. You can see them on the left side, but not only that, we also perform neuropathic pain questionnaires, for instance, the pain detect, and we look at the cornea of these patients. And we initially were able to observe 4 subgroups within this large population of fibromyalgia patients. And what is so interesting in this population, that we could determine small fiber neuropathy in about 50% of these fibromyalgia patients, suggestive that they might have a very different disease than where they were diagnosed with. But I will leave that out of the discussion for now. What you can see here is that we have subpopulations of patients with central sensitization or no central sensitization, and we have patients with and without cornea confocal abnormalities, fiber abnormalities, you can see on top. So we were able to phenotype these patients in 4 distinct groups, and it's our theory that these 4 distinct patient populations within the diagnosis of fibromyalgia should be treated differently. Well, let's continue. We also looked at type 2 diabetes and sarcoidosis. And again here, what is so surprising, that this is a little bit a larger population of diabetes patients, but the subgroups are identical. Again, we have a group with dots that has central sensitization, a group without dots that does not have it, but they have cornea fiber abnormalities. And we also have a group of around 50% without cornea fiber abnormalities. And again, a subgroup of patients with and a subgroup without central sensitization. So phenotypes, now for fibromyalgia, a very different underlying disease, type 2 diabetes and sarcoidosis are more or less the same. And if we compare these three diseases in terms of small fiber neuropathy, so abnormal convocal microscopy on the bottom, versus the ones with normal C fibers in their cornea, with and without sensitization, you can see that the subgroups are more or less of similar magnitude. So on the right, I give you the general observation that in these patient population, about 50% have C fiber abnormalities, 50% do not, and about 20% have no signs of sensitization and 30% do per subgroup. So that's quite interesting. So we have specific phenotypes that are disease unrelated. Now we can also look at the fibers. I've shown you that before, depending on the test. I give them here to you just to give you an indication that now we have specific groups that have specific fiber abnormalities. And what is quite interesting, if you look at the QST data before, these QST data were averages of the whole population. These are data per patient. So one patient is one column. And what is very interesting here is that, in fact, by doing QST, you can perform personalized diagnosis, but not only that, personalized phenotyping, and in the end, personalized treatment. But as you see, the complexity of such graphs are such that a lot of research is still needed to truly understand what phenotype relates best to what treatment. Well, again, patients with diabetes, more or less the same at this population. So again, also at the level of the fibers, the idea is more or less the same. Phenotype your patient, get an indication of the abnormalities, and then hopefully we can find per phenotype specific effective treatment. Well, here I give you again the averages of this population. I added another population of patients, and this is an obesity subset of patients. We have those patients because we're very interested in pain perception in obesity. These are very obese patients with a BMI over 40, and these patients are on the waiting list for bariatric surgery. And you can see the patterns in the patients with sarcoidosis, fibromyalgia, diabetes. You can see that these patterns are more or less similar, but in the ones with diabetes, you can see that it's very different. There are no signs of neuropathy in these patients. They have a difficulty in detecting mechanical pain threshold, whether or not this is fiber related or there are other items related to this. We do not know that. We had expected that this obesity population would look very similar to the diabetes because these patients obviously have some metabolic disorder, but they really did not. If you look, maybe there is some similarity, but overall, I really feel that the QST in obesity gives you an indication that pain in this subpopulation is not related to fiber disease in their skin. But you often see that patients with obesity have pain, but this is often related to their weight bearing on their joints and not related, apparently, in this population to the metabolic syndrome. Now, shortly about treatment. Here you can see treatment effect in patients that have fibromyalgia. And these patients were chosen because they had a defect in their conditioned pain modulation. This is published by Tine van der Donk in the European Journal of Pain 2 years ago. And you can see that treatment with a drug like tapentadol on the left top increases conditioned pain modulation. This is not unexpected. Tapentadol is a drug with a dual function of action. It's an agonist at the mu receptor, although with an affinity about 50% less, 50 times less than that of morphine. But this is most important, it is a norepinephrine or noradrenaline reuptake inhibitor. So it enhances the concept of endogenous pain modulation. And indeed, you could re-engage conditioned pain modulations during the 3 months of treatment in these pain patients with tapentadol. And what's so interesting that we not only increased conditioned pain modulation, but on the right side, you can see that the increase in pain modulation coincided with a sharp reduction of their pain. And you can see that in the remaining graphs, for instance, on the bottom right side, you can see that pain scores decreased significant, and that it was really related to also, this is quite interesting, to C fibers in the cornea. As you can see, the patients with an abnormal C fiber state, they were unable to reduce pain, although they did increase their CPM. So this is the two-hit paradigm, indicating that if you have neuropathic pain and you have defects in your CPM, conditioned pain modulation, apparently you can only be treated when the second hit did not occur, when you do not have small fiber neuropathy. So with a very simple set of tests, you could determine the efficacy, in this case, of tapentadol in your patients, even before you would start treatment. Now, this is another subset of patients. These are patients with low back pain. And this is very interesting to see that we again looked at patients with low back pain that were unable to engage conditioned pain modulation. Again, and these are baseline data. What we observed is that CPM, again, was absent. You can see that on the left side, especially on the bottom. But what was also quite interesting, that their offset analgesia, especially on the area where they perceived the most pain in their back, was abnormal. Again, as a diagnostic of neuropathic pain. So these patients really had a neuropathic component. And when you test temporal summation on their skin, again, what was obvious is that on the back area, the temporal summation was abnormal. Again, an indication of central sensitization. So these patients had a central sensitization, or I have to say it was only on the skin in the back. We call that nowadays a segmental sensitization on the area of the back. And then we treated those patients, and we observed that with tapentadol, pain intensity was reduced. This was related to an improvement of temporal summation in the back, and there was no effect on the arm. Again, improvement of segmental sensitization, possibly due to improvement of neuropathic pain. So we come to the end of my presentation. We've talked about, in very general terms, on quantitative sensory testing, and we see that QST allows precise phenotyping of patients, leading to phenotypical subgroups. The QST patterns may indicate general or segmental changes, such as segmental sensitization. I showed you that in the last slide. Phenotypical subgroups may require distinct therapies. We've shown that for lack of CPM and tapentadol, but lots of work is needed there. And further clinical data will lead the way to improve personalized pain treatment. Well, I thank you very much for your attention. We now have some time for some Q&A. I would like to remind you again, next week we have a presentation on the practicalities of QST. The week thereafter, we talk on treatment and QST. I thank you very much. I'm now gonna stop sharing my screen, and I think the session is now open for Q&A.
So thank you very much. This is the time for your questions. And Professor Dahan, Dr. Niestes, and Dr. Felze will be happy to answer any of your doubts and thoughts arising from this presentation. Thank you.
Thank you all. I see several questions and some remarks. First question relates to conditioned pain modulation. The claim is that there's often the claim that it's related to distraction. And how can we prove that it isn't due to distraction, but that CPM is really related to descending pain modulation? Monique van Velsen will answer this question.
Thank you very much, Dr. Dahan. So it is a very good question indeed, especially considering that when you add a conditioning stimulus in this experimental paradigm, the subjects which you are testing often say, well, maybe it's just because I'm distracted. Actually, there has been quite some studies on this showing that you actually truly activate descending inhibitory tracks that result in pain relief, knowing that this phenomenon also works in subjects who don't know what the actual, what kind of response we're looking for. So what I mean to say is that even if you explain the setup of the experiment, still subjects truly report what they are feeling, and they're not aware of the so-called wishful effect. So in that sense, we can say that we truly are measuring the actual pain experience by the subject at that time, and we are not forcing them into a response that we are looking for. Not sure whether this completely answers the question, but I'm pretty sure that with this setup, we actually measure the true pain perception instead of just modulating the response in a direction that we're hoping for.
Thank you, Monique. The next question comes from the UK. Good afternoon to you as well. It relates to the use of Z-scores. And maybe, Monique, this is also a question for you. Are patient groups compared to data from your own control participants, or did we work with other means, such as the Equista software?
Yes, good question indeed, because for every test that you do, for every QST test that you do, it's really important to realize to what you're comparing your result to. So indeed, when we calculate our Z-scores, we refer to what we call a comparative data set. In our case, we use a data set as published by the German Network on Neuropathic Pain Studies, so the DFNS, which is quite a large consortium that looked at different QST thresholds and temperatures for all the different QST tests that were discussed so far, which were collected in a wide variety of individuals, different ages, different sex, different locations, which all matter when you do QST testing. And by doing this in quite a large control data set, we can actually calculate what the average, but more importantly, what the standard deviation of these responses are, so that we can calculate if people deviate from this more than 2 times the standard deviation. So this is actually what the Z-score means. So in our case, we use the published data set from the German network group.
Thank you, Monique. Many questions now appear. Now, question, I think, for Marika. CPM and temporal summation are site-specific or could be measured anywhere in the body?
Yes, that's a very important question. So what we believe is that CPM is more widespread phenomenon. So it wouldn't really matter where you measure this at what site-specific part of the body. The question always rises because there's a lot of variation and high variability within this test. How should you measure this? And a lot of studies have published on this, where it appears that if you use a heat pain test as your test stimulus and a and water stimulus as your condition stimulus, it gives the most profound and most representative results, and that are also consistent over time. But I think the most important thing is that you define a test system which works for you, and that within your group you always measure at the same spot and the same way, so you can compare your own data, because it's indeed very different to compare between different groups and different trial methods. For the temporal summation, what we believe is more a pain facilitatory test to test whether pain facilitation is present. This is probably different because we believe there's more, as Professor Dahan also tried to explain, widespread approach and a segmental approach. So sometimes you see that there's difference within different body areas. But I think it's important to also check whether there are control data available, or maybe make your own control data, because it's always difficult to interpret these results. But I do believe that temporal summation can be measured segmentally and widespread, and CPM is more widespread phenomena.
One important question, and I forgot it appeared before. Does it work for, and I think what is meant as QST, work for a migraine? And Monique, we are working on migraine currently.
Yes, indeed. It's a very widespread disease, I would say, and really understudied in a sense when we now talk about QST. So actually, it's an ongoing study in our unit looking at different types of migraine and QST outcomes. So we hope to have results in the future. Yeah.
Then about the standardization, Marika, how do we standardize our results and you know, baseline data? How do we get our baseline data? And is it the same every time, or does it differ?
So yes, that's what I tried to explain also in my previous answer. We do make baseline data, and especially for our interventional pain studies. And there is a lot of variation between patients, and sometimes even within patients. So it's very important to take your time to measure it correctly, and always use the same test stimulus and same condition stimulus to control for this variability. If you would want to reproduce results, so it's always best to go back to the papers that published on it and see how they measured CPM. There have been many people trying to make recommendations to see if we could get a worldwide standard paradigm, and up to now this is still not present. But as I said before, if you use heat pain as test stimulus and cold pain as condition stimulus, it's quite, or I think, the best way to proceed forward in case of less variability. But you should standardize as much as possible. So we always standardize also the heat test to, for example, a VAS score of between 5 to 6 on a scale from 0 to 10. And we also try to standardize our conditioned pain stimulus.
Then we have a question relating to hypofunction. Can we apply QST when there is already proof of hypofunction, for instance, due to diabetes or leprosy? Can we then still apply the QST? Monique.
Oh, yes, I think for sure QST is then one of the measurements you can use to actually demonstrate hypoalgesia, as opposed to the clinical reporting of the patients. So it's just a way to objectify, maybe, to translate the symptoms into an actual value. So that's what we do regularly, is demonstrating hypoalgesia by applying experimental, for example, thermal stimuli to demonstrate that there's hypoalgesia.
Yeah, very good. Then there's a question relating to the number of patients that we included in our studies. And Monique, as I remember it well, that the groups are around 50 to 60 patients, the fibromyalgia, type 2 diabetics, the sarcoidosis. Am I correct?
Yes, so as with every group of patients, you have to try to understand and characterize or subgrouping. It's important to realize the number of patients on which you try to do. So we tend to approach it practically. So indeed, we included roughly 50 to 60 individuals for our phenotyping studies. And we already see like quite some clear subgroups within these 50 patients.
Yeah, very good. Then there's a question, will there be notable differences when assessing temporal summation from a mechanical versus a thermal stimulus? And I know that we do both. Do you see differences, Monique? Because we've done them both.
Yes, so this actually relates to the fact if you can, that temporal summation is actually a central phenomenon. So in theory, it shouldn't matter if you apply a thermal or mechanical stimulus, unless there is a clear malfunctioning of either of those sensory neurons. So if it's a central phenomenon, you would expect that either way you would see increased facilitation, regardless of the type of stimulus that you use in the periphery.
And then there's a question regarding the normative values that we use when we use QST to determine small fiber problems, and then compare it to the CCM. This is proximal, while the hands is more distal. How does that compare? Is it comparable, or are these normative values that you see in the skin very different from the normative values in the eyes? I spoke a little bit about it, and I assume you will talk about it next week, but it's quite interesting question.
Yeah, so actually the matter of relatedness of different tests is, I guess, a whole different area you could talk about. So if you talk about nerve innervation in the cornea, in which we do the corneal measurements, it is different from the nerve innervation in distal skin, for example, in the feet. So head to head, you cannot compare the actual values from a skin biopsy, for example, to the actual values from a cornea photo, but this is purely related to the density of the nerves in the end organ. Otherwise, I would say if you look at normative values, it is, of course, important to have a set of normal for individuals without a certain disease in order to compare it. So just as another example, as I've mentioned, there are very quite trustworthy reference data from the German group. We are actually we did, for example, QST on the lower back, and there were hardly any normative values for this location. So in order to understand if it's truly abnormal, you should test different areas within a certain patient, or you should compare it to normal patients without the disease.
Very good, thank you.
Yeah.
Then we get to the final question. And I must say, these questions are really exciting. This is about the difference between segmental and central sensitization. I spoke about that if we see facilitation in one segment, I talk about segmental sensitization, while when we see it on different parts of the body, I call it more widespread or central. Is there overlap between the two groups or patients? You know, how can you distinguish between the two? Monique, Marike?
Marike, maybe you can answer this.
This relates to the study of Tina van der Donk.
Yes, I understand. So, well, how can you distinguish between the two groups is by performing the test at different parts of the body and see how the different tests look like at different parts of the body. So as Albert already tried to explain, is that if you see only in a segmental part alterations, then and not in the whole body, then there's no widespread phenomenon. And there's of course a little bit of overlap between the two groups, because you can have segmental pain facilitation and abnormal CPM responses, for example, but also patients with normal temporal summations or normal pain facilitation and also abnormal CPM responses.
Yes.
So there are overlaps, but it's important, I think, to distinguish between these different groups, because it's important to understand the underlying mechanisms why people experience pain and whether there's differences in perception, also to see whether we can have individualized treatment plans and to better understand the differences between patients within one
Mm.
disease.
Very good. Well, thank you very much. I thank you all for your attention, and I'm looking forward to next week's talk by Dr. van Velzen. I give now the microphone back to Ofried.
Thank you all very much. Thank you all, Professor Dahan, Dr. Niesters, Dr. van Velzen. I'm very grateful for your insights. And I'm also very grateful to our attendees who asked such interesting questions and really contributed in clarifying some of the issues that many of you researchers and clinicians are looking at and struggling with. So thank you very much. Hope to see you next week and have a nice rest of the day. Thank you very much.
Thank you.
Goodbye.
Thank you.